let me just see. Board's working fine? Yeah, works good. Okay, good to see that. All right. So yeah, so I'm coming all the way from Rhode Island. Anybody been to Rhode Island? Oh, a lot of people. Awesome. That's great. Sometimes I get questions about what state that's in, but I guess not with this crowd. Yeah, so it is its own state. Yeah, so what I want to present, you can see I kind of modified it a little because I added a little bit on aggression. And I want to kind of present something that I see quite a bit of, and I think it's a it's a pattern that many clinicians are not aware of, hasn't really been written about, but it's really linking how autism, epilepsy, and either aggression or self-injury are all interrelated, parts of the same issue, and how we have to think about the kids as a whole, not just, you go to this doctor for that doctor for this, and imagine if you had a cold and you had to go to the runny nose doctor, and then you had to go to the cough doctor, you had to go to the fever doctor, and none of those doctors talk to each other, and they each prescribed you a different med. And that's kind of what I'm getting at here. That's a little bit what we do with brain health, right? We send you to like 10 different people. It's one brain, one kid. And I'll give you an example. This is a real case, but this is actually a case. And so he's 18 now, but I'll give you a little sense of what his course was like. And what I'm really presenting here is I'm presenting kids who had autism with regression. And so he was doing really pretty well through those first 18 months. He was a little late with walking, had a little bit of low tone, but he was otherwise doing really well. He was babbling on time. By 2 years, he's using 2-word sentences. So very social kid, not really a real developmental concern except just being a little late with walking. And it was around the 20 to 24 month range where things got a little rocky. See, he had a lot of episodes of otitis media, a lot of antibiotic courses, again and again antibiotics, and in that phase of life, that's where he had a developmental regression. And so this kind of came on, not overnight, but pretty relatively suddenly, where he stopped using words, he stopped babbling. He much of the day he was actually really difficult to console. So we had I just remember gas prices were high when this was happening because his parents were spending every night, they had to drive him for often a few hours just to calm him, and then they had to do like a dance where you have to get him from the car back into his bed and do that without waking him, and then he would wake, and then they put him back in the car and drive for another hour until he calmed, and then back, and so they honestly were driving like 6 or 7 hours some days, and it was like, I think gas was at like, I don't know, like $3.50 or $4 a gallon at that time, which at that time was high. I mean, it was a real, plus the time. And and socially too, that's where he kind of lost that interaction. And so, around 28 months, there's always that lag time, but he gets the autism diagnosis, he starts ABA therapy, he's making slow progress, but it's really he's not quite the same kid he was, around 20 months. He's using single words, but a lot of labeling, he needs a lot of prompting. Continues to make some slow, steady progress through school and through therapy, using more languages, starting to read, a little trouble reading comprehension, but able to decode words, and still like very good vocabulary, but a lot of prompting, doesn't still love to form sentences spontaneously. But it's around 12 when things got really a little crazy. So at 12, he had his first seizure. And that seems a little bit of an odd age, right? Like a lot of the other kids with other forms of epilepsy, they're a lot younger than this. 12 seems a little bit odd, like why 12? And it was a generalized tonic-clonic seizure. It was long. 8 minutes is frightening. If you actually sit and watch a second hand go around 8 times, you could, honestly, your heart could stop when your kid's having a seizure for that long. He gets a workup. MRI and EEG are both normal. So there's a decision to kind of just hold off and watch and see how things go. Second seizure happens, and it was at that point where he started on levetiracetam. I'm not here to knock any particular med, but I would imagine a lot of people in the audience would say, I think you're asking for trouble with that. Again, I got no issue with any particular med, but I think a lot of people would recognize that you might be asking for trouble when you choose that one first. And of course, he had some behavioral worsening with that, and then he was switched to valproic acid. But there was more than just the seizure. So around the same time, around 12, right after that seizure, there's a big change in behaviors, a lot more OCD symptoms. He's starting to have more frequent meltdowns, self-injury, striking his head multiple times, and also acting more aggressively to caregivers. Does this sound familiar? Okay. I feel bad. I mean, I'm happy it sounds familiar in a sense, but I'm not happy. But anyway, and this is an example of what we're talking about. And the head strikes are almost always towards the eye or the temple. And it's usually on the one side. It's usually on the left side. And when you see that, you have to always wonder, like, well, a couple things come to mind, but does he have headaches? Like, what's making him strike the same area? The other thing, too, is the force that's being used. If I did that to myself once, I probably would have to call out of work sick with nausea or something. But he's doing it like 100 times a day. And so it really makes you think about concussion. This is an example, this is a different kid, but this is another example of this kind of self-injury. But this is a really another common area is right here in the hand, like the wrist, the thumb. A lot of kids will bite, and you can actually see that callus formation. It usually is like one side more than the other, but I can often just see a patient walk in, I could look at their callus, I could look at their head, and I know where we are. Like we're having a good time or we're having a bad time. And that's, because those two areas are just so common. And so, you know, these had remained a challenge. And so often that self-injury is brought out a little more with transitioning OCD, but sometimes with the trigger. And, you know, I mentioned headaches always come to mind because he's a non-speaker, so I don't always know, does he have a headache or not? It's not clear, but I have to consider that. And it's really hard to try to console him or turn him around when that happens. In fact, you're better not trying to engage him too much. You're better trying to keep things calm and quiet. But, you know, the problem is he's now, like, this all happens right at puberty. So he's growing, he's getting bigger, and he's getting muscles. And then pretty soon you're taller and bigger than all of your teachers, all your therapists, and your mom. And you know how it is in school. Like a lot of people go into this tend to be women. There aren't a lot of men, so it's a little scary when you have a physically big guy with muscles getting very aggressive. And what's really the pattern that's really emerged is that you get into a behavioral swing where the OCD is really bad, the aggression's really bad, and then the seizure happens. Oh, and he doesn't sleep, like 2-3 nights in a row, no sleep. Then you almost can be like 90% sure the seizure is going to happen in that next 24, 48 hours. Like you just know it's coming. Seizure happens, and then he's good. He's good for about like, you know, a week maybe, and then the wave starts coming, and you could see it with the OCD, you could see the self-injury, you could see it builds, no sleep, seizure, good. And so this is when, this is when it really brings you to tears sometimes, because this is when a parent says to you, I'm almost looking forward to the seizures, right? I mean, that's how bad it is. The seizure is like their respite in a way, and that's a tough place to be. And this kind of prompts this idea of like, what do you call this sort of almost a second regression? I mean, he had a first regression when he was, you know, around 20 months, and now at 12, suddenly things get really bad again. And it's almost, you know, prompts that kind of consideration, like something has happened here really significant in his life. And this is what I've seen in a lot of kids. So usually that first regression is around 12 to 36 months in that ballpark. It often is related to infection or immunization. And, you know, I have to cough it because you can't say it. Anyway, but no, it's like, so sometimes it is a vaccine-related regression too, but something inflammatory. There's often an inflammatory trigger for that first one, and so and a lot of the kids did have his history too, where they had a lot of antibiotic courses, et cetera. Then they really have a substantial loss of language and socialization and an increase in irritability sometimes, but then slow, steady progress, and then right as testosterone kind of hits or puberty hits, like there's a major change again. And that change usually is this combination of aggressive behavior, self-injury, and seizures. They go together, which is why I'm kind of presenting. I really believe they're all part of the same thing. They're not separate, and you really shouldn't have an epileptologist who's doing one thing and then a psychiatrist doing another and a developmental pediatrician doing a third. I mean, you know, this is all one brain, one issue, and they have a major impact in life. So if you want to just look at the aggressive self-injury stuff and what that means for families, it's really common. So with kids who have autism, about 70% or so are going to have aggressive behaviors. It's more common towards caregivers. So unfortunately, God bless all the moms there, but unfortunately mom is usually the kind of the target of this. It's because you love them the most and you'll never leave them. And they love you, but often they're the recipient. And then non-caregivers is about 50%. And you don't see this in things like intellectual disability. You don't see this kind of rate of aggression. It's something that is really very unique in autism. And if you look at why kids exhibit these behaviors, it's often not for a purpose, right? Like there's no spoiling involved here. I mean, I think a lot of the kids either experience pain, that's always a concern. It could be abdominal pain, could be pain from other sources, headache perhaps. There might be a lot of issues with transitioning. There could be sensory integration issues. So there could be a host of different things that are playing into it. But it's not like the kids want to feel this way. And it's not like it's a directed issue. And so that's why it's not really amenable to behavioral therapy, right? So, often a lot of the kids I see, their ABA therapists are working on this, but it's not working for them. And that's because this is not a behavioral issue. This is really more like they're in pain or something's very, very uncomfortable. And I feel bad for the kids because they really do need help. It's just that a lot of the kids are non-speakers. It's hard for them to communicate those issues. For the kids who are working on things like spelling, it's also very hard. If you're in pain or you're very unsettled, it's going to be very hard to really work on something like a spelling technique when this is going on. We need to find ways to medically, kind of settle things. And what's really hard is that this issue becomes more problematic than the seizures or epilepsy, which is kind of shocking to say even at a conference like this, because seizures are really bad, and we all hate seizures. But this is actually the thing that's causing sleepless nights at home for everybody. This quote where an unbearable level of exhaustion is something I hear a lot, and I mean it's just incredibly sad to have like from this one paper of a quote of a mom saying that she feels like she's in jail for life, but it can be that bad. And it also really drives up our medical system. So it's actually really common that kids wind up getting hospitalized in part for these behaviors because it can be so hard to manage. And 10% of kids who've exhibited this being hospitalized is really a high number. And the medical expense is so much higher, and it's usually because of these issues. And also partly because medicine doesn't have really good answers here. And so, I just mentioned, like, we have to think of different possible causes when kids get into this. OCD anxiety is often accompanied by it, pain, sensory integration. I do think communication's a really big piece. If we can get better with communication techniques, I really think it helps. And I've seen it kind of settle kids over time. And then, transitioning is a big piece as well. So lots of things we have to consider. And we have to try to make sure that, I think pain is one of the biggest ones for the physician to try to settle. So, for example, if you had a cavity, would you say it makes sense to just be prescribed aripiprazole or risperidone for your cavity? And nobody would say yes, right? Because that's not how we treat a cavity. I've had a lot of kids with cavities who develop a flare-up of aggression, but they're actually treated with like aripiprazole or risperidone. I've seen that happen because it's a non-speaker. And so we have to recognize, like, sometimes kids they're showing us the signals, they're communicating, but sometimes we have to listen better, right? The thing here that is really interesting is weight waxes and wanes. So for those who've experienced this, how many would say there's a full moon relationship? Yeah, I mean, there is, right? And with seizures too, that's actually been documented, that there can be a full moon relationship. And I know this because I get the phone calls. So, and I get the phone calls like, why are all the calls coming at night? And then I'm not really paying attention to the lunar cycle, but then I realize, oh yeah, okay. But no, there's something there. There's other things too. There are other environmental triggers, I think. But we go through seasonal changes. We go through change of in New England, the weather changes every day, so that's a real problem. And then the time change, that's another issue too. Daylight savings creates some issues. So sometimes there are explainable causes, but I'll tell you, a lot of times there's no explainable cause. So you don't have to overly rack your brain for every possible cause. Don't go crazy with it, because sometimes there really is not an answer. But what I would say is it behaves, I think of it a lot like waves on the beach, where you have a pattern that you start to see, and every now and then you get hit with a tsunami. But there's a real pattern to this, and you start to think about how do you ride those waves, like almost how do you, like a surfer, like how do you kind of surf this with a plan that's going to catch this ahead of time. And I've done that for the seizures. Sometimes I'll up the seizure meds because we know it's coming. Or I have a plan like we're going to be aggressive these next 3 days because this is, the sleep hasn't been where it should be. So we know seizures happening, and it can work. It can work pretty well. So there's ways to try to ride those waves. The key is we have to listen to the moms on this because they're the ones who can tell us, what the cycle looks like and what the signals look like. And trust that and just kind of work out a plan that seems to work well for the family. And I'll just mention real quick, like the anatomy, this is real simple anatomy. This is all the brain anatomy I know. That's it. I don't go into a whole lot of detail with that. No, but this is all you need to know sometimes, is that there's a kind of a combination of factors that play in together. The prefrontal cortex is really important because our frontal lobes are really important for impulse control, executive functioning. And when you get hit with, the amygdala is listed here too because that's our fight or flight, right? That's going to release adrenaline. When you get hit with that fight or flight and you already have a little trouble with your frontal lobe and your impulse control, that's a bad combination. And the reason I put the brainstem here is just to remind you that our autonomic system connects with every organ in our body. So, with the gut-brain thing, like that's a two-way street. Our heart's going crazy too here though, right? You could see it in the kids. A lot of the kids who have the fight or flight, their pupils are wide, they get sweaty, their heart is racing if you can measure it. It affects their gut, so really everything gets affected. And the gut is a two-way street because a lot of times the kids also have abdominal pain too, and so that's triggering fight or flight, and then that triggers more gut stuff. It just goes around and around and around. So that's just a reminder though how the brain is connected to everything. Little talk on epilepsy too, because I think it's important to think of both sides of this. So I mentioned the aggression, self-injury. Epilepsy is part of this. And it's kind of amazing to know that a third of kids with autism will have epilepsy, and a third of kids who have epilepsy at a young age will have autism. There's really you kind of see two main patterns here. So I'm talking here about the kind of that later kind of seizure pattern. But you have some kids, we have the Dravet booth here. So Dravet syndrome is a good example where the kids will have seizures first, usually 4 or 6 months. They're immunization sensitive too. A lot of them will have their first seizure after DPT at the 4 to 6 month range. And then the epilepsy is really pretty tough. It's really bad. And so what happens is the epilepsy is so bad, people forget about the fact that, hey, this kid's not speaking. So sometimes they don't get an autism diagnosis till they're 6, 7, or 8 because we've been fighting so much for the epilepsy, we sort of forgot about development. But they're very different than the kid I'm presenting, right? They don't have that kind of second regression quality. You have other kids who had the epilepsy much later. So they were kids with autism. The families had gotten really kind of used to everything involved with therapy in school and already fought for services and they had to get out of district placement. They went through all that stuff. And then suddenly at age 12, things like the wheels fall off. And then the epilepsy starts. And then this is a whole new, like, how to relearn the system. So that's the group I'm talking about here. And a couple of things we have to think about as neurologists. So we always have to think about so the behavior and the regression and the epilepsy seem to all go together. Is there a role for like what's happening physiologically? Could those spikes happening that we see particularly during sleep, could that be part of why behavior is affected? If possible, to get a 24-hour EEG, it's really important to try to get a sleep EEG just to know what's happening. And we know sleep is really important in this because the kids often have seizures when they're not sleeping. We have to think, too, about this issue of Landau-Kleffner. So Landau-Kleffner is a term we use when kids have a really high level of spike waves at night during sleep, and they tend to lose language or developmental skills associated with that. And in a lot of kids, in about 25% of kids, they don't have a clinical seizure. So that could be an example of something that causes a regression. And it is important in the first regression when they're young to think about a 24-hour EEG. It's also important in the second one. And there's a separate thing, too, to think about. So like Landau-Kleffner and autism and regression, they're very similar in a way. So Landau-Kleffner kids tend to be a little older, usually after 3. The kids with autism and regression are earlier. But in both cases, there's that epilepsy quality that's mixed in with the developmental piece. And there's a third kind of category, which is childhood disintegrative disorder. That's when kids are much older, when they have an autistic regression. They're usually over 3, but like a lot of these kids are 6, 7, or 8, and then they have an autistic regression. And that's associated with epilepsy about 70% of the time. So again, really clear connection between the epilepsy and the regression. They're kind of really two sides of the same coin in a way. And I will make the case here that kids with autism and epilepsy really are different. We have to think of this as a different population than just run-of-the-mill epilepsy. This is something unique, and we have to think differently about treatment. And the group I'm with at Brown did put together a case series to try to see, are there differences? Now, these weren't the kids with these weren't necessarily kids with that regression, but we do see a few differences. Like one example is kids with, you can't see any of this, kids with autism are more likely to have generalized convulsive seizures than kids with epilepsy alone. Kids with autism are less likely to show an MRI abnormality. If you remember, my patient had a normal MRI and a normal EEG. And that's a really common pattern. I think the EEG is more commonly normal too. And based on those findings, there was a decision not to treat after that first seizure to allow a second seizure to occur. But I actually think, of these kids I've seen, I think they've all had that second seizure. So I think we probably shouldn't wait. We have differences in med choice. So if you remember, levetiracetam was picked first. You're going to see that a lot less commonly in kids with autism. Whereas sometimes you'll see topiramate used more commonly in kids with autism. And some of that reason is because topiramate causes weight loss. And a lot of the kids are on atypical antipsychotics for the behavior. And so weight gain's been an issue. I would just caution on, well, we have to caution on atypical antipsychotics anyway because they cause weight gain, they can cause gynecomastia. Long-term, I think it's a really problematic choice. We always have to have an off-ramp. If that's being used, I get it, because sometimes the situation's bad, but there has to be an exit strategy. And I'm just going to caution, too, on using Depakote with an atypical antipsychotic. You're really asking for a lot of weight gain. And our goal here is not to give kids type 2 diabetes. Or make them less healthy. Our goal is to move towards greater health. And it's interesting to note, too, this is a separate paper that I did with Richard Fry, who spoke yesterday on autism and epilepsy. But when you look at the therapies that parents, this looked at every therapy, like including a lot of alternative approaches, like things like supplements were included in this. But when you look at every therapy, actually the one that parents report as the most effective is actually ketogenic diet. And that doesn't actually surprise me, because when you think of what the keto diet does, or a low glycemic diet, it lowers inflammation, and it boosts mitochondrial functioning. And when you read really about some of the underlying mechanisms that may play a role in autism, particularly autism and regression, they kind of boil back to inflammation, mitochondrial functioning, which makes a little bit of sense because mitochondria are the power plants for the cells. And inflammation, you could think of it as it's like sucking the energy out of the system. All your energy is going towards inflammation, not towards fueling that brain. But this too kind of suggests there might be treatment avenues that we might need to consider more so when you have autism and epilepsy rather than epilepsy alone. That maybe we need to think of this differently. And another question that kind of comes from this are kids who have epilepsy and aggression, is it more common that they actually had this regression? It's a little confusing. I might accidentally say aggression when I mean regression, and if I do that, it's just because they sound so similar. But I did look at this in my patients, and the summary was yes. So in kids with regression, so kids who had that regression at like 2 years of age, it turned out that the prevalence of epilepsy was about 50%. So now imagine at 2 years, like I see a kid who had a regressive autism, already I can kind of anticipate that there's about a 50-50 chance that epilepsy is going to be an issue. And the issue of aggression is almost like 3/4 of the kids. So now I don't think I'm going to mention that to a parent of are there parents of 2-year-olds here? Okay, I'm not going to mention that to a parent of a 2-year-old on like that first or third visit, but I have to think about this. I'm thinking about this differently because I don't want to crush a family. It's probably not what you need to hear right away. But I will say this, like maybe as a clinician, that means that are there ways that I could find, is there something I could find that might help avoid that? I think there's a chance here for prevention as well. And when you look at both together, so if you look at the kids who had regression, about 44% have epilepsy and aggression, compared to 23% of kids who did not have regression. So I think it's kind of making the argument that there really is this higher risk, higher rates of epilepsy and aggression for those kids who had a developmental regression. And the kids who had a developmental regression, we have to think of them differently, and we have to use different treatment avenues or search for better ones. And I term this second regression syndrome, but this is not something that like your neurologist or developmental pediatrician or psychiatrist is really looking at, because it's not really published. I mean, I published it, but nobody reads it. But, you know, but, well, it's under-recognized is what I'd say. And as a side note too, most developmental pediatricians sign off when the kids are around 12, like, or maybe sooner sometimes. So often the developmental pediatrician's already signed off, and your neurologist often doesn't want to talk or do anything about the behavior. And sometimes they give you meds that just make the behavior worse, right? So, and then they say, we'll go to this other doctor for the behavior. So I really do think that's a problem. We can't keep that kind of status quo. And I really think the other thing too that has to happen that's different here is we have to think, I mean, when you think about treatment, we have to first find out what the root causes are. We have to really think about causation. And I think there are a lot of, now I don't think every kid's the same obviously, but I think there are a lot of things we have to consider and think about differently than patients who have other types of epilepsy without autism. Like I mentioned, neurotransmitter disorders, sometimes, like, could there be something that affects certain neurotransmitter systems? In the case of Fragile X, for example, there's a change in a metabotropic glutamate receptor, and glutamate's the excitatory neurotransmitter in the brain. And so maybe some kids have issues there. Growth factors I mentioned, because in tuberous sclerosis, it's really common to have autism and epilepsy both, and that issue relates to the mTOR pathway. mTOR is a cancer gene, it's a growth gene, and there's more growth in those kids that can lead to tumors, but that also plays a role in the epilepsy and the development. And they can respond to different treatment avenues. I mentioned Dravet before. That's more of a channelopathy. That's a sodium channel mutation that causes both autism and epilepsy. Metabolic, I think, is probably one of the most underlooked things by physicians, but I show the mitochondria here. I mean, you know, the brain is our gas guzzler of the body. The brain consumes a lot of fuel, and in a kid who's growing and developing, that energy production is critical. And so if you have a little trouble with energy production at baseline, and then you throw inflammation into the mix, that's probably a really bad combo. So I think we have to think about how our metabolism, our energy production, and our immune system might be interacting to cause that kind of regression. And we have to really think about etiology differently. This is what Richard Fry spoke on, but this is an example where his research on vitamin B9, which is folate, I think is really interesting, and none of the neurologists seem to know it, none of the epileptologists know it, none of the developmental pediatricians know it, but there have been multiple clinical trials on the use of folinic acid, which is a version of vitamin B9, and the fact that it improves both symptoms of autism and epilepsy, and particularly in kids who have antibodies that block the folate receptor. Now, this is like low-hanging fruit, because here we're giving vitamin B9. This is a pretty straightforward, easy treatment to go after, and yet nobody seems to want to go after it. And so that's something, you know, we have to kind of think differently, I think. And this is an example where this could be overlooked, and we're treating this kid their brain might be deficient of folate, and they have what's called cerebral folate deficiency. We're treating them with meds that have nothing to do with that, and we're getting nowhere. And so I think what a lot of that gets into is you have to think of the whole patient, right? It's not enough to say, I'm the, you know, so again, saying I'm the epilepsy doctor or I'm the behavior doctor is just as ridiculous as if you come in with a cold and I'm saying I'm just the cough doctor. You got to go to the other guy down the hall for the congestion because I'm just dealing with the cough, right? That's exactly what we do when it comes to the brain. We have to think of the whole patient, but it's even a little worse than that, because then we treat the brain like it's like this separate living thing totally apart from the body. So as I say, a lot of the kids who have GI pain or have something as simple as a cavity, sometimes their symptoms flare up from that, and it's time to just think about the whole patient. And so all that's really critical to change like the framework of how we approach this. And I would say, I'll leave you with, this is Providence, by the way, in the winter. We have a nice little skating rink downtown. But I would say that the change that has to happen is the epileptologists have to get better at thinking about behavioral side of things. I think psychiatrists, developmental pediatricians have to learn a lot more about epilepsy. And we have to in each kid, we have to really search for underlying medical causes. We have to really search out etiology and try to think differently about this, because really what we're doing right now is we're just treating symptoms and we're not treating cause. And I have a whole list of slides after this on immunology and epilepsy, immunology and regression. I won't bore you with all that. I also think I'm out of time, but just to note, like, I think that's a really important pathway here. And I could share those if we have more time, but that's up to you. I'd also welcome questions too, because I think that's equally valuable. So I don't want to kill the question time. Oh yeah. So stress definitely relates to seizure, but I think in this population I'm talking about, a lot of the kids I see with autism and especially self-injury regression are living in constant fight or flight. So that's a little more than just stress. And that's, so the fight or flight, so imagine how you feel when you get into a near car accident and your heart's racing and you can't really function for about 20 minutes. You pull over, you don't just get back in your car and start driving because you're just too amped up. And it's extremely uncomfortable. Okay, and imagine feeling that way for 16 hours a day. And that's where a lot of these kids are living. And there are different treatment avenues. I have all other talks on that too, like how we treat that, how we can treat that differently. But we have to think differently about how we manage that. So we have to really recognize kids who are living in fight or flight and manage it. So the number one thing is not to induce more trauma on kids who are going through this. So I've seen kids who, they get into fight or flight, and then how do we manage it? Well, we get a big guy at school to bear hug them in a quiet room. And what would that do? So imagine you had the near car accident. Some huge dude comes and he physically restrains you. And then you have to go back to the same site where that happened and do it again tomorrow. And then the next day, right? And I really think a concern I have is that I really think we're training the brain to do this. Brain gets better at this, and we're just making it worse and worse. So number one is de-escalate that. Give the kids a safe place where they know that this isn't going to happen. They can transition. They have staff that can try to feel out their behavioral patterns, and if they're building, take them for a walk. Have a sensory moment. Go on a swing. Let's not get the big dude to hold you down. And then that's one. But then two is maybe we need to treat the adrenaline too. So that might be part of the equation. We need to, I use propranolol quite a bit. It's a beta blocker, and it's a blood pressure pill. But it's so simple to use, and it really calms that fight or flight. And so that's it's a relatively safe, simple treatment to consider. And those things, I guess what you're getting at, those interventions improve the seizures. If you really regulate the behavior better, you'll get the seizures better. The converse is not always true. As mentioned, when you have a seizure, it actually does calm the brain for a while. And so sometimes behavior is better after a seizure. But that makes me think about what's the mechanism there? Is that really just a reflection of the fact that maybe the brain was too hyperexcitable and I need to calm that excitation? So I do think a little differently about medication. So one reason, for example, topiramate can be a consideration because it downregulates AMPA, which is a glutamate receptor. So you're downregulating glutamate with that. N-acetylcysteine is another example where it kind of downregulates glutamate. I use that a lot for OCD symptoms. And that's it breaks down to glutathione. It's liver protective, so it's a very safe supplement to try. Sometimes we'll use memantine, which is an Alzheimer's med, but that blocks a different type of glutamate receptor. And that can sometimes be helpful for kids with extreme sensor integration issues or aggression. So it gets complicated, right? But and then we have to be sure too that that the kids don't have ongoing allergies or chronic infectious symptoms. And I didn't really get into the pandas, but that's a whole other can of worms to open up. But you have to think too: is there chronic inflammation that we have to treat? And maybe it's something as simple as strep, or it could be, in my neck of the woods, could be Lyme, or it could be black mold. But we have to kind of look at all those things. Is there something ongoing so all these different triggers have to be considered, but none of that is in none of that's in our neurology training, right? So all that stuff I just learned from talking to moms, and that's it. Pretty simple, yeah.
Can we get a copy of your slides and can you put up your information?
Yeah, I'd be happy to. I'll figure out how to share the slides. I guess there might be a way we could put that online for everybody. I'll find that out. Yeah.
You say that you learned all this from talking to moms
Yeah, but the best way to present it to your doctor is that.
What's the best way to present to a doctor?
Yeah.
To not come across as we know better than you, but to say, hey, this is what we're seeing.
Yeah.
Can we look at these different aspects? That sort of thing.
Yeah, I think there's a couple ways you could do it, but well, so first, I don't mean to knock dads because I'm a dad, right? But I'm also, I also recognize that, my wife has a certain maternal instinct that I don't share. She's just has that. And that's an incredible gift. And and as a physician, so this is a little aside, as a physician, you can either trust the maternal instinct or not trust it. And it depends on whether you want a happy life or kind of a miserable professional life. Right? And so I chose the easy path. But really, it leads you in a good direction. And so, but dads are great too. But I think you have to. Some of it involves. You can usually size up your doctor pretty quickly, probably in 5 minutes. You kind of know where they're at. Same thing's true of a teacher. So if the question you ask yourself as a parent, and this is true for doctors or teachers, is does that person see my child? Right? If they don't give you that impression that they really see your child there, they're probably not going to be the person you're going to have that discussion with. And you might need to look elsewhere. You know what I mean by that, by seeing your child, right? Like I love it when, so you have to recognize a lot of kids, many of the kids they may be a non-speaker, but they're intellectually as advanced or more advanced than I am. And so, and even though they don't show you, they may not show you with their eye contact that they're listening. And so, you approach the kid and you talk to them like anybody else. And then you listen to the parent about who that kid is, what they're into, what they're like, and you get to know that kid as an individual. And if you see somebody, a teacher or a physician who does that, they'll listen to you. But if you see somebody who's just like staring at the computer screen, you might need to think elsewhere. The other thing, but you have two ways you could do this. So most doctors are not going to do the integrative medicine approach. I'm okay with as much as I could take it to, but I'm not like a Lyme expert or something, right? So, but I try as much as I can. But I'm totally okay if you have like an integrative physician you work with or a pediatrician or somebody. I'm okay taking on those insights because the truth is I'm not happy with writing risperidone and valproate and calling it a day, right? That's not a very rewarding thing for me to do, especially when I'm making the kids less medically healthy. So if you have somebody who's got good ideas, either yourself or like an integrative physician, I'm more than willing to work with them on the things that I don't know and let them do the parts I don't know, and I'll try to work with the other parts. And I think that's where a lot of my colleagues though fall short, to be honest. Oh yeah.
I'm sorry, I came 3 minutes late, and I would like to ask for an explanation a little bit more about regression. Are there some like tools, tests, like to know about that, or is what we have seen in our kids' development? Yeah. Is the regression something related with cognition, or more one we have noticed during development? And the second one is she's displaying some aggressive behaviors at school mainly, and sometimes with ABA therapists. She is in pre-puberty, but most of her ages doesn't show seizures. They just show like epileptiform discharges, yeah, or interictal discharges. How I can know if what she's having, the behavior she's displaying now, belongs to autism or seizures, and how I can explain like the school, because I try to explain the school what is KCNA2, but it seems they were not interested. So how I can explain like the staff and the people what is happening with her?
Okay, all right, yeah, there's a lot here to get into. Let me know on time too, just so I know, because if I run over, you tell me to shut up if I'm running over. But there's a lot here to get into. So, okay, I have some things that are philosophical that I'll share and that I can't really fix. But number one is, I think school has to probably focus less on diagnosis and more on the kid in front of them, right? And that's one. Number two is you always get like some PhD from school who will tell you all about your kid who doesn't know anything about your kid. All you really need is somebody with like a third grade education, a lot of common sense, who can feel what your kid is feeling and try to help redirect them to something that just, through common sense, that just would work when they're building. And so a lot of that is nonverbal communication. The teachers need to learn about how the kids are communicating their symptoms and their feelings, because the kids aren't going to verbally say, hey, I need to, like, this would be a great time for me to go take a sensory break. Like, it's not going to come out like that, but it's going to come out through their stimming, through their body language, and you need somebody who can, a gentle touch, maybe let's go take a walk now, like somebody who can see those symptoms and kind of intervene. I always look when aggressive behaviors are happening, I have to look at where they're happening and when they're happening. Is it more at home, more at school? Is there a certain time of day when it's most frequent? And then try to trace that back to see what the underlying contributions might be, and then address those. Because it's really complex, and it takes a long time to go through the history to really understand what's contributing. The epilepsy side, a lot of kids actually don't have seizures, but just have epileptic abnormalities on EEG. It always raises the question, do we use a seizure med in that case? There are times where we do. We try not to if we don't have to, but it does tell you that there's a physiologic disruption to the brain. Now, like, does ABA therapy treat a physiologic disruption to the brain? No, it doesn't. So it's not a behavior. It kind of tells you there's something here that's not just behavioral. There's something bigger. Now, I don't know that a seizure med's the right choice, right? That depends on a lot of factors. But I have to really consider that, and I have to then begin to look at all the other things that are important for brain physiology, like sleep and nutrition and like just circadian cycles. And so it's complex. It takes me like 2 hours to sometimes try to unravel it, and I still don't know what's going on after we do that whole history, but it's a process, right? And I think it's okay to educate school about the specific diagnosis, but what I really want them to do is just look at the kid and just think about what that kid's going through, what their experience is, what makes things better, what makes things worse, how do you motivate them in a positive way? Like, that's kind of what I want them to do. Not because sometimes they ask me for detailed medical records. I don't know, what do they do with those? They see the kid every day. Like, what's the point of that? Like, you see the kid every single day. Like, it's the same kid. If I tell you you have a certain gene mutation or something, how does that make any of this different? It shouldn't. So, anyway, yeah.
For a lot of our kids, including my son, sleep is a big trigger for. Yes. Sleep is a big trigger.
Thank you. Sleep is a big trigger for seizures or lack of sleep. What can we do, or what can we add? What can we take out of the diet? What supplements can we add? What can we do to help our children sleep better?
Yeah, I think one thing, so I'm wearing an Oura ring. I'm not pitching this product, but I actually think sleep tracking is a really interesting idea. I think sensory integration-wise, this is not for everybody to use a sleep tracker, but I think when it comes to epilepsy, we don't have a system yet of looking at sleep data and saying, okay, this is a time I have to be careful for seizures. But I really do believe that you can imagine that you can surf the waves. So if I see 2 days of bad sleep, and I have patients where I know this is true, like you get 2 days of bad sleep, you know a seizure's at risk, and that might be your warning sign. And so it's not going to forecast it 100%, but I think we do have to pay attention to sleep. How to manage sleep. One thing just to be careful about, we use a lot of antihistamines sometimes for sleep, and I think hydroxyzine or Benadryl can work, but they can also be bad for seizures. That's one of the risks, that they can bring out seizures. What's interesting is serotonin. If you boost serotonin, that's generally good for seizures. So something like trazodone might even improve seizures. I use that sometimes in Dravet syndrome, and the seizures get better. I use that a lot. We have to think about that in kids who have like 5 a.m., 6 a.m. seizures. Their meds are declining. So one thing I do is sometimes I use an extended release med at night. But the other thing I think about is sometimes something like trazodone that boosts serotonin, that's the time in the day when the serotonin is at the lowest, is 5, 6, 7 a.m. And so sometimes boosting serotonin might be effective there too. So a consideration, but so we have to think, when we think about treating sleep, we do have to think about using things that are safe for seizures. And sometimes I'll use supplements too, like lemon balm and L-theanine are very safe to use. like ashwagandha. There's a few that are very safe to use. Even valerian root, which was used for sleep and anxiety, used to be used for epilepsy about 100 years ago. So that's an interesting option. So, so it's a combination of meds.
And they're safe to combine with the medicine?
So I always have to go through each individual supplement and individual meds, to make sure we're safe,
So I don't, is it on there? Okay. So you talked about your other slides that have autoimmune, and if you could include that, we talked about that.
Yeah.
Is that, so my question is, or comment would be, could you just expand a little bit on the relation between that autoimmune and OCD? We've done IVIG, had a hematoma, and now we're refusing to do IVIG.
Yeah.
But OCD in our home is really high.
Yeah, I mean, the question's about immune functioning and OCD, and I think you can argue too so I had a whole separate slide deck I won't have time for, but kind of gets into the fact that immunology, I think, is important for both the behavior side and the epilepsy side. We know immunology is important for epilepsy too. One thing to keep in mind is cytokines, interleukins are really interesting because our neurons have interleukin receptors. They have cytokine receptors. And when you have high pro-inflammatory cytokines like IL-1 beta, IL-6, IL-8, those are all pro-inflammatory, TNF alpha, they actually cause the brain to be more excitable. So you get increased excitation. When you get increased excitation, you get increased anxiety, OCD, but you can also get increased seizures too. Think about an excitable brain. An excitable brain is not sleeping, anxious, right? You have more pain too, so pain sometimes is tied into that. And when it's really bad, a seizure. So I think what's happening for some kids have more of a hyperinflammatory response, and then they may have abnormally high cytokine levels, and bringing that down would ease that excitation. But most people don't use that as a treatment avenue. It's not as common. California now has the legislation for pandas to get IVIG coverage, so that's great. Most states don't have that.
It's interesting because when I tried to ask about PANS, I don't get any response, but if I ask about autoimmune encephalitis, I get IVIG.
Yeah, that's the game. You know the game. Yeah. I have a whole separate talk on PANS and autism, but we don't have time for that. But these are all important. These are really important topics, though.
We do have about 2 minutes left.
Oh, I do.
Before the next session needs to come through.
Oh, that's good. So we got time for another. Yeah, I'm gonna ask how we could share them. So I'll ask Brad Levy if there's a way I could just make them available to everybody, and I'll include the cytokine stuff there.
Hi. So right now we are dealing with, so she's ready to go through puberty. So we are going through extreme anxiety, hyperactivity, and seizures have increased. The seizures have been resolved by Epidiolex and Onfi. Anxiety, depression, ADHD is at like an all-time high. So we wanted to know, do you feel like those two medications that are fixing the seizures can have a adverse effect on like depression and anxiety?
Yeah, so I think everybody heard the question. It's like, could this combination of Epidiolex and clobazam worsen behavior on some level? There are two things I think of. One, so there's a paradoxical worsening that happens when you fix seizures sometimes. And we see this most dramatically in epilepsy surgery, because in epilepsy surgery, you just, boom, you fix the seizure. Sometimes behavior gets worse. But that's like, we use the term forced normalization in a way, but it's basically the child's coming into their normal behavior. Now, I don't know that that's what's happening for you, but I just mentioned this for other patients. When you improve seizures, sometimes the hyperactivity is worse because they were so suppressed from the seizures that now they're just, the energy is better, they're just relearning everything. And so you get this overall behavioral worsening. But if it's if that behavioral worsening is accompanied by improved language, improved focus, improved performance at school, I would ride that out, right? If you have a worsening behavior and you're not seeing those other improvements, then I kind of worry that, okay, maybe the seizure meds are actually causing side effects, right? Because both of these are possibilities. Regression in school. Okay. Yeah.
Like she'll get very stressed out if she can't figure out how to do something.
If it's
And that's not like how she was before.
so that would worry me more about side effects being the issue. And it is worth noting, like some of the kids, if kids on autism and Epidiolex, sometimes that pure cannabidiol makes them a little more hyperactive or affects their sleep. It's a little bit of a unique finding I see in kids with autism. So I've had some kids who've had more troubled hyperactivity there. Clobazam's a little different. I mean, that usually makes you a little tired, but for some kids it makes them disinhibited too. And so I would worry that there could be side effects here, and then I'd have to think about, do I scale back the meds slowly and carefully? That's a hard decision when you have seizure freedom, right? But you might have to think about that. And if you do scale them back, is there something else that would be a better option long term? I approach that.
I think her neurologist is like, well, our job is done. Like she's seizure free, so we're good. And we're like, but she's not.
Yeah, so like you went to the cough doctor and he fixed the cough, right?
Yeah.
So no, it's not done, right? Because I think the question remains, are these direct side effects of his interventions? He has to take ownership of that. Tell him I said so. Okay.
Thank you.
You could be here all day, obviously, so we need a break for the next room, so are you gonna be outside?
Yeah, I'll be out. Yeah. Thanks. Oh, thanks.